Good morning, ladies and gentlemen, and welcome to today's webinar on the EU vaccine strategy. My name is Andy Klom. I'm the acting head of the European Commission's representation in Ireland. I'm delighted that there has been such a high level of interest in today's EU vaccination strategy webinar. It's a topic that concerns everyone and all of us. Now, as you may know, the European Commission is coordinating a common European response to the coronavirus outbreak. The EU vaccine strategy is an example of the power of European collaboration and of European solidarity in action. The EU has secured a broad portfolio of over 2 billion vaccine doses for European citizens, for our neighbors, and for third countries. Today, I'm delighted that we have John Ryan to speak with us. John is the Director of the European Commission Public Health Directorate since 2016. John is an expert in public health policies with experience gained in both the EU institutions and the Irish Civil Service. And John is also a Fellow of the UK Faculty of Public Health. John will give an overview of the vaccination strategy from an EU perspective, and then John will be available to answer your questions about the vaccination strategy. Maybe to take you through some practicalities, we have up till round about 11:30, 11:45. If you would like to ask a question, please send an email to the following address: events@europeanmovement.ie. I'll repeat that: events@europeanmovement.ie. The email address will also be shown at the bottom of the screen. And if you want to be active on social media, please use today's hashtags, which are hashtag #SafeVaccines and hashtag #VaccinesWork. With that being said, I'd like to hand over to you, John, and your presentation.
Thank you very much, Andy. Thank you for the possibility to speak to you this morning and to speak to our listeners and viewers in Ireland. I also like to thank the European Movement in Ireland for being associated with the organisation of this event. The topic of COVID and the topic of vaccination against COVID is, I think, one of the most topical issues you could have chosen for today's event. And I hope that I can, in a few words, explain the way that the member states and the Commission have been working together to try and combat this pandemic. And then, even more importantly for me, to have the opportunity to dialogue with people afterwards. And I hope that that will be a very interactive session, and I'm sure there will be a lot of questions. So without any more delay, let me go into my first slide, which explains that from a legal point of view, public health policy in the European Union is officially a member state competence. This is something which is an important issue because it determines how far the European Commission or the European Union gets involved in a particular policy. It's all set out in the treaty. And as regards public health policy, the primary responsibility is with the member states. Now, there are some exceptions as regards cross-border health threats, where we have legislation on surveillance of communicable diseases, but also on alert systems. We have a very high-performing electronic alert system which links the member states together with the Commission. We also have a system where there is a common risk assessment carried out at European Union level. Rather than having 27, we have one analysis of the situation and one risk assessment, which I think is an important basis on which policy making and risk management can then take place. So these are the elements of our legislation on cross-border health threats, which dates from 2013. And just in passing, let me say that every major event which we have encountered over the last years, I'm thinking in particular of the last flu pandemic in 2009, but before that, the SARS epidemic, All of these were the occasion for the European Union to make a jump forward in terms of its legislation. So I'm sorry to say, but it's true that the European Union is very often in the public health field, and in this field in particular, it's moving forward by leaps and bounds, but very much based on the experience we've had with a particular outbreak, a particular epidemic. Now, we also have EU pharmaceutical legislation, which is important for today's presentation because pharmaceutical legislation covers, of course, vaccines. And this I'll explain in more detail, but the legislation has an evaluation part and a formal authorization part. The evaluation part is done by the European Medicines Agency, which is now based in Amsterdam. And the authorization part, in other words, the legal authorization for putting medicines on the European market, is given by the Commission. So these are the two legs of our pharmaceutical legislation. And again, I'll go into more detail on that. And we have, of course, then several agencies. There are two mentioned there on the slide, which work to support this public health policy. First of all, European Medicines Agency, which, as I said, does all the work on evaluation of medicines coming on the market, or if there are any changes in the formulation and so on, the agency would also be involved. And secondly, the European Centre for Disease Prevention and Control, it's a long name, which is based in Stockholm and which has the responsibility for collecting data on communicable diseases and for doing the risk assessment that I mentioned earlier on. So they analyze, for a particular threat, what the risks are for Europe and what the possible measures might be to combat that risk. And they also have a strong role in preparedness planning for the European Union. So moving on to our next slide, and more specifically in relation to vaccination, we recognized in early last year, in June of last year, that there were pharmaceutical products, in particular vaccines, which could play an important role in combating the spread of coronavirus. And the Commission proposed a policy on this to the member states in June of last year. And all of these documents are, of course, public documents, so you can have a look at them just by Googling the title, you'll find the document. But basically, the key elements of this vaccine strategy were to accelerate the development, the manufacturing, and the rollout of the vaccines for COVID. So these are the three elements which you really need. You need to be able to research and develop a product. You need to be able to manufacture it at scale, and you need to get the vaccines out of the factory and into the vaccination centers, into the hospitals, and so on. The second pillar of this strategy was to ensure the quality, the safety, and the efficacy of these vaccines. And that's, of course, the part which is managed by the EU legislation on pharmaceuticals. And the third axis, part of the strategy, is in relation to equitable access. In other words, trying to make sure that we obtain sufficient quantity of vaccines to be able to vaccinate everybody in Europe who needs to be vaccinated. And secondly, to be able to support the global solidarity effort. You should be aware that this vaccination strategy is also based on the fact that the European industry in manufacturing vaccines is extremely important in worldwide terms. And therefore, I think it was important that we had a common approach to vaccine strategy rather than 27 different approaches. So turning now to the next slide, the key idea in the vaccination strategy from June of last year was to actually put money on the table in respect of the portfolio of vaccines which we thought had a good chance of making it to the authorization stage. Don't forget that in June of last year, there were no vaccines in existence. It was simply the idea that we should prepare vaccines. And therefore, what we wanted to do through this process was to make a promise to the pharmaceutical industry that we would support the development and the manufacturing and the purchasing of these products. And therefore, this was the whole concept, that we would actually intervene before the product was actually manufactured in order to support its development and to guarantee a guaranteed market for these products once they had been authorized. And to do that, we used the European support instrument, the emergency support instrument, which is actually a major source of funding in the COVID outbreak. And we mobilized the financial elements in the EU budget in order to be able to support, in particular, the production and purchase of vaccines. The next point is in relation to how we changed our legislation, and this was another important aspect, because normally speaking, the European Medicines Agency waits until they receive the final dossier for a new product before they start the analysis of, checking the clinical trials, checking the efficacy of the product before they give a recommendation on its authorization or not. What we did here was to actually advance this process so that there is what we call a rolling review carried out by the European Medicines Agency. In other words, as soon as the clinical trials start for a product like a vaccine, the European Medicines Agency will already have its eye on the file. It will have its eye on the clinical trials. The company will share the elements regarding the progress of the clinical trials and any problems which might occur. They will share that with the European Medicines Agency, which means basically that you're saving several months, if not years, on the control of the evaluation of the product by the European Medicines Agency. They're doing it at the same time as the product is being tested. And this meant that we could actually advance on our calendar. And on another aspect in relation to regulatory framework is that we also try to speed up the authorization of the manufacturing capacity. When we have to check quality and the safety of the manufacturing plants themselves, pharmaceutical plants, and that was something we also tried to speed up. Now, on the side of the European Medicines Agency, on my next slide, you can see that the European Medicines Agency set up a specific task force which was reviewing the scientific data and providing advice on the development plans and conducting the rolling reviews, which I mentioned a minute ago. So in other words, the agency was much more hands-on, I would say. Instead of sitting back and waiting for the different companies to actually give them a final dossier, they were much more proactive in supporting the industry in producing these products and completing their application. The rolling review is something that happens before the final submission is made, and only when the data is sufficient, the company actually makes the formal application for authorization. We also signed a memorandum of agreement with the companies to allow more easy rollout of the products. For example, you can imagine all the complications with packaging and with labeling. If all of these things have to be done in the usual way, they have to be packaged in all of the EU official languages, and the labels have to be, and the leaflets, the product leaflets have to be produced in all the languages. What we did here was to arrange that the leaflets would be available online rather than physically producing the packaging, which takes a long time. And we also made special arrangements as regards the presentation of the products. For example, multi-dose vials, for instance. That the vials, the bottles of the vaccine could be produced and packaged en masse rather than individually. So all of these things were designed really to speed up the post-marketing or the post-manufacture stage, so that once the products were ready, they could be released as quickly as possible. And of course, then we issued a conditional marketing authorization for these vaccines, considering this was the quickest way of actually getting the authorization approved. Once the risk-benefit analysis is favorable, the marketing authorization can be modified if there's new data which comes online. So it's really an effort on our part to try and make the authorization process as flexible and as rapid as we could. Now, as regards the next slide, on the negotiation side, this is the first time that we have negotiated as a European Union to purchase a pharmaceutical product at this scale. We have procured products before, jointly for pharmaceutical products before, but this is the first time we've done it at such a large scale. Now, the whole idea was, as I said, to have advanced purchase agreements with the industry in order to support the development, and then afterwards to guarantee the supply of the product. Before we actually launched into these negotiations, which were held simultaneously, we had exploratory talks with the companies to find out whether it was reasonable to go into those negotiations in the first place. An example of this might be that they might have had a very nice idea scientifically, but they might have no manufacturing capacity. Or they might have manufacturing capacity, but they had no nice idea. So we had a couple of cases like this where, you know, the fact of opening a negotiation would not have actually led to the purchase of a final product, because the company was not ready to, was not in a capacity to actually deliver a final product, either because they didn't have the concept or they didn't have the way of manufacturing. So anyway, we entered into negotiations with 6 companies, and these refer to 3 different types of vaccines. Now you might say, why did you negotiate with 6 companies? We negotiated with 6 companies for the simple reason that we wanted to have a diversified portfolio. You can imagine what would have happened if we had negotiated with 1 company for a specific type of vaccine, and then there was a problem afterwards. If the authorization was not granted, for example, the result would be we would have no vaccine available for the European population. So that's why we wanted to spread our risk as far as possible across different companies and across different types of vaccines. And I can't but repeat again what I said a few minutes ago. We're talking here about products which don't exist. At the time we were negotiating and signing these contracts, the products did not exist. So it's a very special situation. In other words, you're looking at concepts of manufacture of vaccines, and you're looking at purchase of products which don't actually physically exist. So it's a very strange operation to get your head around. So we negotiated 6 of these contracts for 3 different types of vaccines, and you can see that in the second bullet point there. So the viral vector vaccines concerned AstraZeneca and Johnson & Johnson. The protein subunit vaccines concerned Sanofi and GSK. And the messenger RNA technology concerned BioNTech, CureVac and Moderna. And we're also finalizing our negotiations with Novavax and Valneva for further types of vaccines. And the CureVac and Novavax vaccines are under rolling review at the moment. They have not been authorized. And the Janssen's one we expect to authorize shortly. So you can see we have certain products which have successfully passed the barrier of the authorization, and they're now on the market. They're being injected into our citizens around Europe. And these are the AstraZeneca vaccine, the BioNTech Pfizer vaccine, and the Moderna vaccine. And as you can see, there are others which are in the pipeline and which will shortly come online and be delivered. So let's move on now to the delivery on the next slide. And in line with our strategy, once the vaccines have been authorized and produced, each vaccine will be available to the member states on the same day and at the same conditions. Now, this is a very important point, because you can imagine what would have happened if we had done what we did before. In 2009, for example, with pandemic flu, the 27 member states purchased themselves individually their vaccines. It's even more complicated than that, because if you take a country like Germany with the Länder system, or a country like Italy with regions, they were actually buying on a regional level as well. So you had some regions in Germany which had access to the vaccines, and some which had access on a different level. So the whole advantage of this EU negotiation, I would say, is that everybody was on the same playing field. Everybody was playing in the same direction, and everybody was able to benefit from the result. So it's really, I think, an extraordinary success that we managed to get this through, that the countries have access to the same vaccine at the same price and at the same time. So there are no big countries, no small countries. Everybody is getting the vaccines they ordered on the same day. Now, the Commission suggested that there should be prioritization, of course, because you don't want a lottery for vaccines, and therefore, when you have supply which is coming progressively on stream, as the products are applied for authorization, as the authorization is granted, as the manufacturing commences, of course, it's not something where you can roll out the product to the entire population of Europe on the same day. It's a progressive thing. And therefore, we suggested that there should be a prioritization involving, for example, the vaccination of healthcare professionals, persons over 60 years of age, and the majority of the delivery is foreseen to be completed already this year. Just to put this on a slide for you, the next slide, you can see we have secured so far almost 2.5 billion doses of vaccine, and this is going up all the time because we're negotiating separate additional contracts. And you can see the BioNTech, Pfizer, Moderna, AstraZeneca, Johnson & Johnson, CureVac, and Sanofi. Some of these are authorized, as I said, 3 of them are authorized, but the others are coming, and if they're successful in the authorization, these are the amounts that we have reserved. Next slide. Now, the Commission, in the middle of all this, was thinking ahead, and we proposed a paper in October where we suggested that the member states would need to look at the organization of their health services to deliver the vaccines, because it's a huge enterprise to actually roll out the vaccines. It's not something you can do with your normal existing mechanisms. We suggested that the member states should really think between October and December on the capacity of services to deliver vaccines. So some countries have established vaccine drive-in centers. Others have taken disused concert halls and they've turned those into vaccine centers. Everybody has done something different, but what I'm saying is that the member states really thought about this and tried to increase the capacity. They also trained people to vaccinate, or brought back people who were retired, mobilized medical students, mobilized the pharmaceutical sector. You know, there were many efforts made to increase capacity. Easy and affordable access. If you have a vaccine center which is in the middle of an industrial estate, there is no public transport, obviously it's going to be difficult for vulnerable populations to get there. So how do you organize yourself in order that the vaccines are available physically to the people who need it, and not geographically, in a place where it's very difficult to get to? The deployment of the vaccines with different characteristics. This means that some of the vaccines require specific refrigeration, And this was really a problem for some member states because they didn't have the fridges required for that particular vaccine. So this was an immediate technical logistical problem which we had with one of the vaccines, that the deployment was slowed down in some of our member states by the lack of sufficient refrigeration. And finally, all the clear communication on the benefits, the risks, and the importance of vaccines was also part of the approach which the Commission suggested, so that people in the public would know what the benefits were of vaccination and what the technologies were and what the potential risks might be. If I look on the next slide, we went into some more detail on the priority groups, and I mentioned healthcare, long-term care facility workers, particularly social workers, but also persons over 60 years of age, people who have pre-existing medical conditions, essential workers, people who can't social distance because of their situation or their work, and other disadvantaged socioeconomic groups, thinking here particularly of the homeless, migrants, travelers, people who may be more exposed because of their socioeconomic group. Next slide. Now, you might be saying this is all very selfish. The European Union is just focusing on its own protection and its own citizens. And in fact, we have been accused of sitting on a stockpile of vaccines. I wish we had a stockpile of vaccines. We don't. But I want to explain in a few words what we've been doing, because we really have been trying to look at our own health, but also at the global picture at the same time. And the main mechanism for this global response to COVID is called the COVAX facility, COVAX, COVAX. And the idea is to bring together the countries internationally to accelerate the development and manufacture of vaccines. Because Europe is not the only place that vaccines are manufactured. You obviously have Russia, you have China, you have India, you have other big producing countries. And the idea was to bring these countries together in a coalition to try and speed up the development and manufacture of vaccines, and to guarantee fair and equitable access for every country in the world. That is a big, ambitious agenda, as you can imagine, but it's something which we're signed up to and which we're working towards. And we have confirmed our participation in this process, and I'd be happy to give more details of that later on. Next slide. So the Commission is contributing financially, but we're also working with the partners in the COVAX cooperation and with WHO in order to do all the other things, what I mentioned in the October paper from the Commission. You know, all these questions about preparing yourself. There's no point in just sending a plane load full of vaccine somewhere and then hoping that something will happen with those doses. There's a whole chain that has to be put in place of training vaccinators, putting in place the vaccination centers, making sure the logistics are there so the vaccines can be transported, that they can be refrigerated, that there's a vaccine registry so that we know what happens if there are any side effects. There's all these things which need to be put in place, and the countries we're talking about here are not the most well equipped to do that. And that's why we have started, before we talk about distributing vaccines to every country in the world, we have to make sure that the conditions are in place, that the healthcare systems are in place to support this vaccination rollout. So that's where we are at the moment. And of course, financially, we have been investing very heavily in this whole process, because it's not only a question of the European Union being prepared, but there's no point in us all being prepared here if our neighbours are not prepared. And if we just have re-importations of cases going on, this is completely impossible in a globalized society. Let me just say a few words on the next slide on our targets, our ambitions in Europe. So the Commission published a communication in January where we proposed that at least 80% of health professionals should be vaccinated by March. That's the objective we've proposed. and that 70% of the EU's adult population should be vaccinated by the summer. So that is the target figure that we're looking at the moment. And I don't think it's impossible. If you look at one of your closest neighbours in Ireland, I think it's quite possible that it can be done. And it's just a question of having the vaccines in sufficient quantity and having the systems in place to roll out those vaccines on time. These are the figures we're looking at the moment. Next slide. And you might say, well, where are we today? I have figures here from the 17th of February, and you can see that some countries have done better than others. If you look at the bars, the vertical bars, these are the vaccine doses administered in total figures. And then if you look at the dots, the blue dots, which are on the slide, these are the vaccine dose administered per 100 people in the population. So you can see it's not the same thing, basically. The percentage of the population which has been vaccinated differs from the total number of doses administered, of course. And you can see also on that slide that one of the smallest member states in the European Union, if not the smallest, has administered 10%, over 10% of its vaccine, of its population are vaccinated, which puts Malta at the top of the league table at the moment. But I don't want to put the member states in league tables. I'm just pointing out that their countries are in different situations there. And you can also see the position of Ireland and where they are in terms of delivery of doses and percentage of the population. Next slide. I talked earlier on about communication. Well, it's not as if we're talking here about simple communication without any historical background. There has been a huge vaccine hesitancy movement developing over several years. It's not a European thing, it's an international phenomenon. And therefore, we're communicating about the new vaccine, but we're also doing that against a situation, a context where there is skepticism in the population about vaccination. The most recent time we saw this was 2 years ago, when there were huge measles outbreaks in Europe, including in Ireland, because of the reluctance of parents to vaccinate their children against measles. And what we're trying to do now is to communicate positively about the safety of vaccines, their efficacy, the systems we have in place for pharmacovigilance, for checking up on side effects, which may eventually happen, and to try and inform people and be as open and transparent as possible about these vaccines and the effects that they have. So when we don't know the answer, we say that we don't know the answer. And we are quite open about some of the aspects of this vaccine which are unclear at the moment. For example, whether it would stop transmission. But these are examples here of some of the campaigns which the European Union has been producing. Every member state, including Ireland, is also communicating actively on vaccination in order to try and respond to these types of questions. And just a few more points before I finish. On my next slide, we have a publication from last week where we're looking at this problem of variants. You know, you probably heard about the UK variant, the South African variant, Brazilian variant. There are lots more of them. It's quite normal that a virus will mutate as it moves around, particularly from person to person. But also the virus itself is not a stable virus. And therefore, you have new variants which are appearing. And some of these are more transmissible than the original virus from Wuhan. The problem with all of this is that, of course, the vaccines were designed and engineered to meet with the original virus and not the mutated virus. And therefore, this is why the Commission proposed a strategy on the 17th of February last week in order to prepare for these new variants that are coming our way. First of all, we have to detect them, because sequencing is necessary. Sequencing of the genome is necessary in order to identify these variants, and very few member states actually do this sequencing, or if they do, they don't do it to a sufficient quantity. So what we're trying to do is to provide incentives to step up the scale of this sequencing so that we can better know what the new variants are. Secondly, to provide incentives to develop new adapted vaccines for these variant viruses. That means investing in research. It means investing in new production facilities. Yeah. The third point is we have to speed up the approval process for the vaccines, so we don't have to wait a year before they're approved. It's a small change which would take place in the existing approved vaccine. So we don't see why we have to start from scratch with the approval process. What we're really talking about here is re-engineering the vaccine in order to meet the new variant. And that may not require the entire approval chain to be carried out a second time, if you see what I mean. And finally, of course, this whole issue of manufacturing capacities and how we can invest in new manufacturing capacities in Europe so that we don't find ourselves in difficulty with supply. And my final point, which I'd like to make on the next slide, is the issue of joint procurement. Now, we have not only been buying vaccines like mad, but all last year and still today, we're in the process of buying products which could be useful for dealing with the outbreak. Now, everybody remembers the beginning of last year. There were no gloves, there were no masks, there were no gowns, there were huge shortages. So the European Union signed a contract on behalf of 37 countries in Europe, EU countries and neighborhood countries. And now we have contracts in place which allow the member states to buy all of this PPE, this personal protective equipment, which they still need. They still need when they're vaccinating, you need to wear gloves. So even as part of the vaccination campaign, we still need the masks, we need the gloves, we need the gowns. It's not over. It's something where we need a continuous supply. Ventilators, you remember all the debate about ventilators and the fact that there were not sufficient ventilators in some countries and too many in others. We have a joint contract now which everybody can use to purchase the ventilators they need. Laboratory equipment, testing equipment in labs. Ventilation, vaccination supplies, all the needles, the syringes, the alcohol wipes, which are needed in huge quantities. Rapid antigen tests, we've just signed a contract for rapid antigen tests, which are the tests which give quicker results. And finally, we're also procuring therapeutics like remdesivir to reduce the severity of the outbreak, and also other products which are coming on the market which have some therapeutic benefit for people who are in a hospital setting. Now, there is a website on the next slide which I'll give you now. It's the Europa website, where you can read everything I've said in 100 times more detail, and you have access to all the documents. The whole thing is there. It's in all the EU languages, and you'll be able to read and answer any questions that you might have. Thank you very much.
Thank you very much, John, and please allow me to express my gratitude for such a clear and comprehensive presentation of what is a complicated topic, but one that sort of holds our attention continuously in these current and difficult times. Now, I'm sure there are many questions out there, and please, ladies and gentlemen, keep on sending them to events@europeanmovement.ie. I have a few questions that have already come in, John, that I'd like to sort of present to you, and maybe I can take a few at a time. There's a question from a member of the general public who's asking, is there scope to speed up the regulatory approval process in order to tackle new variants and keep vaccinations safe? There's also a second question about the EU vaccine strategy that only covers, as you explained, a number of vaccine producers, but there's been talk about member states and even individual regions in member states entering into negotiation with other vaccine producers. So the question is, can member states negotiate parallel agreements, and is that a good move?
Thank you. So I can answer those two questions. We actually have a regulation which is in progress at the moment in order to examine how we should speed up the authorization process for the vaccines which are redesigned to deal with the new variants. As I mentioned before, we don't think it's necessary that you start from scratch. It will be necessary to re-engineer these products, these existing vaccine products, to take account of the new variants. It will be important that they are tested and they show their efficacy against these new variants, but we do not think that these are new products, and therefore the authorization process should be certainly simplified and shortened, because the actual safety of the vaccine envelope, if you like, is something that would have been checked and authorized when the product itself was authorized. What we're talking about here is just changing or rejigging the vaccine in order to make it more responsive to the new variant. So there is legislation in progress there, and of course we need to balance this by the need to make sure that the product is safe and that public confidence is maintained. So there are a number of different conflicting interests there, I would say, and what we're trying to do is speed things up but make sure that the fundamental protection that we have in our current system is maintained. On the second point, the EU vaccine strategy is quite clear. It's an agreement which is signed by 27 countries and the Commission. There's an article in that agreement which forbids the participating member states from purchasing the same vaccine separately. So if they wish to procure extra supplies, or if they wish to procure different vaccines, that's a different question. And there are member states who are, for example, part of the EU negotiation. They've signed the advance purchase agreement. They can now order and receive the vaccines which were jointly purchased, but they're at the same time talking about additional supplies of other vaccines, for example, the Chinese or the Russian vaccines. So these are parallel producers and parallel purchasers which are not forbidden by the system, because the system is an agreed amount for agreed vaccines. And if somebody does something in addition or separate to that, then that's not a problem.
Okay, thank you, John. I have a question from Paul Gannon, who is the director of the European Anti-Poverty Network in Ireland. And he's asking for more information about the EU strategy in relationship to global solidarity and ensuring adequate access to vaccines for poorer countries. That's one question. There's another one I have here from Kieran Walsh of the Munster Express. He would like to know, we have vaccine factories here in Ireland that could be utilized for vaccine production. For instance, Sanofi has one in Waterford, and there are others. Could they be persuaded to do so here in Ireland, as is already being done in other countries like Germany?
Thank you very much. So on the first point, I think we should not underestimate the scale of this global vaccine effort. Now we have 190 countries who are involved in the COVAX International Vaccine Coalition. Most of those, of course, will be, I would say, receiving countries rather than donating countries. So we've got to take that into account. But this gives you an idea of the scale of the thing. If the European Union had a hard job bringing 27 countries into a common negotiation for vaccines, and we've managed to purchase 6 of them so far, 3 of which are authorized. So we have guaranteed sufficient space for production for the European citizens. And I've explained all that. Imagine how much more difficult and challenging it will be to have the same process for 190 countries worldwide. I mean, it's a huge challenge. We're very happy, in addition to the European Union, that in October of last year, China decided to join this process. And I'm very happy as well to announce that on 21st of January, the USA also joined the process. Now, considering that the European Union has been a leading member of this for almost a year, you can see that these two late entrants, shall we say, are really late entrants. But we hope that we'll be able to work with China and the US now to really catch up and to make sure that the provision of vaccines for the international market will be accelerated. We are planning, as part of this international operation, 3 billion doses for delivery this year and next year. So that's the scale of what's being considered as part of this COVAX operation. And some advanced purchase agreements have actually already been signed with some of the producers, both in Europe and in India and in China. So COVAX is not a theoretical process. It's something where the money is there, the advanced purchase agreements have been signed, and the products would be delivered. Already in the first quarter of this year, by the way, some of these products will already be delivered. So I think as the other issue is the donation issue, because you probably noticed that the population of the European Union is much less than the quantity of vaccines that we have actually ordered. So we're not actually sitting on a stockpile, we're sitting on a promise of a stockpile. And what we're planning to do at the moment is to try and encourage our member states to donate spare capacity and spare orders to countries outside Europe. And we're starting this already in respect of our neighboring countries, where a number of donations have already been organized, particularly to the the Western Balkans, to Ukraine, to a number of other countries in that region, which have a very urgent need of vaccines, which are basically our neighbors. So these are the countries where we're focusing on at the moment in respect of donations. On the second question from Kieran Walsh, in respect of sharing the production facilities, it's clear that the production capacity of the vaccine industry in Europe will need to be scaled up. So what we're trying to do is to eliminate bottlenecks in the current production, to accelerate the production of the vaccines, and to upscale where feasible. And this involves, for instance, suspending some of our competition law, because, of course, under normal circumstances, under normal competition law, you would not be encouraging companies to come together and sign agreements to share the production of a product that would be seen as somehow contrary to good competition law. In this case, we're actually encouraging companies to support their coordination. So if you have a company, I won't quote any names here, but if you have a company which has a vaccine product, it's been authorized, it's ready to go, but it doesn't have enough manufacturing capacity. And in another member state, you have an empty factory because the company doesn't have an authorized vaccine, but it has the factory to manufacture that vaccine. Then perhaps part of the manufacturing capacity of the second company can be mobilized to support the first. And that's actually happening at the moment. And I would say that if there is spare manufacturing capacity in Ireland, that could certainly form part of the solution. In other words, if there are product lines and manufacturing lines which could be mobilized quickly to support the upscaling of manufacture, we have certainly nothing against it and everything in favor. And I would just mention in that respect that the European Investment Bank has already been working with BioNTech, which is one of the companies with the authorized vaccine, in order to support the upscaling of their manufacturing capacity. So it's not only a commercial question, there are funds available for this operation and for supporting this scaling.
Well, thank you very much, John. I have two follow-up questions, sort of in the same direction. One from Michelle Hennessy of the journal.ie website, who's asking, has the Commission given consideration to using the Sinopharm or the Sputnik vaccines? And a second question from Dave Keating, who's with the TV station France 24, and he's asking about the Moderna vaccine. Will Moderna really have the production capacity in Europe to justify the extra purchase this week of 300 million doses? And can Moderna scale up its European operations?
Thank you for these two questions. So the first question from Michelle Hennessy on the on the Russian and the Chinese vaccine, I could also extend perhaps the answer to cover the Indian Serum Institute vaccine, since that's also being sold at the moment. Essentially, it's not a question of what the Commission wants here, it's a question of what the company wants. And there have been exploratory discussions with some of these companies which were not part of the advanced purchase arrangement, shall we say, and which now have a product which is on the market and available. And therefore, the first step for these companies is actually to make an application for authorization to the European Medicines Agency. That's how it works. In other words, the manufacturer of Sputnik or Sinopharm or the Indian Serum Institute would actually have to approach the European Medicines Agency with their dossier and make an application. There are no shortcuts in the system, in other words. The European Medicines Agency is there to ensure the quality, the safety and the efficacy of any pharmaceutical product, and there is no side door into the European market. This is a procedure which our own companies have to follow, and it's only logical, I think, that companies outside Europe would also have to follow the same process. On the second question from France Van Ketra, and in respect to the manufacturing capacity for Moderna, clearly this is a contractual issue. And if Moderna has signed a contract for 300 million extra doses, the Commission and the Member States will be expecting that they have the manufacturing capacity to deliver those doses according to the contract in the timeline that's provided for in the contract. So 300 million doses, again, don't have to be produced on the first day. There is a production schedule. And there is a best efforts clause in the contract, which means basically that if there's a manufacturing problem, we're not going to force the company to produce the vaccines in an unsafe factory, if there's a contamination or something like that. So this means that the normal contractual arrangements will apply. And if there is a quantity which is provided for, if we paid for that quantity of vaccines to be delivered, we would expect the company to keep to its contractual obligations.
Thank you, John. And maybe good to follow up then with some questions from the general audience coming towards us about some of those, difficult issues. There's a question from Jerry O'Sullivan who's asking, is there a target level for EU vaccination that, when reached, we should be able to return to a normal level of economic, travel, and personal behavior? And I have a second question, but I'm not sure who's asking it. I think a person called Charlie, who wants to know that the first vaccine was developed by BioNTech in Germany. Why has the rollout been so slow in the EU compared to other countries like the USA, and that have achieved a much faster rollout?
Yes, so thank you very much for these two questions. In respect of normal life, I think we all are very hopeful that things will return to normal as soon as possible. And this is, in fact, the great hope which we have with the vaccination campaign, that this will bring us closer to that point where the outbreak will be under better control and the consequences of infection will be reduced. We were talking earlier on about what the effects of the vaccination are. The principal effect of the vaccination, as far as we know today, is that the severity of the infection is reduced. So in other words, we don't know whether the vaccines will actually stop a vaccinated person transmitting the virus to somebody else, but we do know from the clinical trials, and this is stated in the authorization process for the 3 vaccines that have been authorized, we have clinical proof clinical trials, that the vaccines are extraordinarily successful in reducing the severity of the disease. Extraordinarily. I mean, I don't know of another vaccine which is quite so, other vaccines which are quite so high performing, I would say, in reducing the severity of disease. So this would clearly have a contribution to reducing the burden on our health systems, protecting vulnerable populations, and these are the people we are vaccinating first, together with the healthcare workers and essential workers and so on, as we pointed out. So this will automatically reduce the pressure on our health systems. And then the question really is, when can we reach that target level of vaccination of the vulnerable groups and vaccination of the whole population, which we were talking about earlier on? Because only in this way can you slow down and stop the transmission of the virus in the population and reduce the effects of that transmission. So we are looking at the moment with our scientific experts to see thresholds. In other words, if it's possible to establish thresholds where if you have below a certain rate, you then lift certain measures. And we're trying to calculate this at the moment, particularly in respect of lockdowns, in travel restrictions, and so on and so forth. You'll appreciate that it's complicated because you sometimes have local outbreaks which require local measures. I don't think it will be possible from a technical point of view to have one single threshold for the whole of Europe. I think we'll have to do it on a regional basis. And you've probably seen these maps which we publish every week with red, green and yellow and grey to show the intensity of the severity of the infection across Europe. So you can see that countries are different, regions are different. And therefore it's important that we take this into account when we look to going back to a normal life. But vaccination will certainly be one of the things that will bring us to that point. And on the second point, on the speed of the rollout, the point I was making there was that we have purchased simultaneously for 27 countries. Of course, if one country had gone ahead and paid the price for going ahead on its own, they might have been able to cut a few weeks off the delivery schedule. But believe me, if you're competing with countries like the United States of America, and if you're ordering a small quantity, as would be the case in Ireland, for instance, the possibility of actually getting that delivery earlier than the United States, or even at the same time as the United States, would be rather tricky to achieve, I would say. I don't want to be too speculative here, because we have an Irish American president now, so maybe we could have achieved some special results since the election. But my point is that we have really made the effort to work together as 27. The quantities we were buying were major quantities. And the fact that the 27 were negotiating together gave us great purchasing power, I would say, and also the effect of solidarity that every European citizen could have access to these vaccines on the same day, at the same time, at the same price. And that's really something where I think a few weeks more or less on the delivery schedule was justified by the fact that we did have this common approach.
Okay, well, thank you, John. I guess in that respect, there's a few follow-up questions about, the purchasing power. I have a question from Aaron Burnett, a freelance journalist, who's asking the UK and the US reportedly have spent 7 times as much as what the EU is spending per capita on developing and purchasing vaccines. And he's suggesting the EU should have used a lot more of its economic clout to help boost vaccine production capacity much earlier. So, to what extent was an early capacity development part of the EU's vaccine strategy? A second question I have from a member of the public, Lorcan Blake. He's asking, with the delay and slow delivery of vaccines in member states, is there an urgent need to revisit the commercial capacities of the procurement people in the European Commission? John.
Yes, so thank you for these 2 questions. Now, on the first question, we did not start to invest in our pharmaceutical policy and our pharmaceutical industry, I would say, with the arrival of COVID. We have legislation which is in place. The legislation is designed to encourage and support and to solidify, I would say, the pharmaceutical industry in Europe, which is a very important economic sector in Europe. Yeah. So this regulation, which we have, this European regulation on pharmaceutical products, is part of our industrial policy. It's not something which began or finished with COVID. And I think it's incorrect to start calculating the amount and say that the US and the EU and the UK paid 7 times or invested 7 times more than we did, because that does not take account of all the investments which are taking place in parallel, which may not be counted as part of that. So a good example would be, for example, the European research program, which has been supporting research into pharmaceuticals in Europe, particularly the Innovative Medicines Initiative, where the pharmaceutical companies in Europe, together with the Commission, use the research program in order to finance the development of new products. And if you have new vaccine technologies on the market today, and if we were able to produce them as quickly, it's because of research and it's because of the investments that were made. I'm not saying that the European Union is the only place in the world where research takes place. What I'm saying is that this research started several years ago and is part of our strategy to reinforce the pharmaceutical industry. Now, we have proposed that there should be a strengthened approach to our preparedness and making sure that we have pharmaceutical products ready when we need them. And if you remember my slideshow towards the end, I mentioned that we had an initiative announced last week where we are proposing that the preparedness for pharmaceutical products, development of pharmaceutical products, stockpiling, all of this should be accelerated and funded from the EU budget. So this is something we've learned a lesson, if you like, from the current crisis, that the level of preparedness of our member states was insufficient, and we're proposing a strengthening of that process so that for future outbreaks, and you know that we've just had an alert yesterday from Russia about avian flu and infection of humans by avian flu. This is an example, and also in Guinea of Ebola. You know, these things are not going to go away. So hopefully COVID will go away someday, but we'll also have other threats, and it's important that we're ready. And I don't think it's a badge of honor, quite honestly, to say that a country or 2 countries have spent 7 times more than we have. We have our vaccines which are being delivered and our people are being vaccinated at the moment. Every member state has access. And if we were able to do it for a more economical price, I think that's not to our dishonor. In fact, it's a result of negotiating together as 27, and that's what the point we were making earlier on. On the second point, when we were talking about having this system in place for the future to be able to purchase, to identify what the threats are, to develop the countermeasures, vaccines, therapies, and so on, then to manufacture those and to stockpile them. This is the idea we proposed last week. And this would entail automatically, and this is my answer to Lorcan, this would entail automatically scaling up the capacity to do that together. For us, there's no point in 1, 2, 3 member states having systems in place and nobody else. Yeah, nobody is safe until everybody is safe. And this is very much the case here. We need to make sure that in the same way as we were able to purchase the vaccines together, we should be able to do that, but do it in advance. We shouldn't be doing this in a crisis. We should be doing it in advance. And that's what we're proposing at the moment, to put these systems in place, identify the threats, identify the potential therapies, develop and manufacture them, and then arrange for their stockpiling and purchase in advance, insofar as we can.
Thank you, John. I'll take 2 more questions before we have to finish up. I have a question here of Fabrice Folliot, who is the director of En Route Consulting. And he's asking, what is the view of the Commission on countries that are taking individual action to get greater access to vaccines, in particular, the case of Hungary buying Russian vaccines? And a second question that is multiple times coming in, could you say a bit more about the issue of equitable access, and particularly the priority given to vulnerable groups? How come that is working out differently in different member states?
Yeah, so these are two interesting questions. I would say, in response to Fabrice, that the parallel negotiations, as they're called, are quite negligible, looking at the big picture. First of all, because they're exactly that, they're negotiations, they're not deliveries. Whereas with the European Union vaccine strategy, with the joint agreement, a unanimous agreement of the European Council, a total 100% participation of all the member states in the process. So let's not forget that this is a joint operation where we use the EU budget, we negotiated together as 27, and we sign contracts as 27. Now, what is going on is, it's true that there are some countries who are negotiating in parallel negotiations to the extent that that's allowed. I mentioned that this is the case, for example, if they're procuring or buying a vaccine which is not on the list of authorized or agreed vaccines, then they're free to do so. But the Russian vaccine, which was mentioned by Fabrice, is not an authorized product in Europe. And there are negotiations and discussions going on with the European Medicines Agency, but no dossier has been submitted so far. And it's the same thing for the Indian or the Chinese vaccine. So countries are free to do this, but if you look at the overall picture and the overall size of the European joint purchase, this is negligible. And I think countries would be much better advised to wait for the delivery of the scheduled delivery of the 3 vaccines and shortly the other vaccines which are coming. And in the meantime, of course, to maintain the social distancing measures, the wearing of masks, the control measures in hospitals, the hospital systems, in order to keep infections as low as possible until the vaccines arrive. On the second question on vulnerable groups, this is interesting. Each country has its own approach to defining vulnerable groups, and the vulnerable groups are different in each country. You can imagine a situation like Greece, for example, or Italy, which have large influxes of, or had large influxes of migrants, that the challenges for reaching those vulnerable populations might be different to the situation in other member states where maybe the migrant populations would be fewer. I was reading with great interest calls in the Irish press yesterday for prioritization of the traveller community in Ireland for vaccination purposes. And it's true that I think each country will have to define its own vaccination strategy as regards vulnerable groups. I live here in Luxembourg. I'm working in Luxembourg, one of the few EU officials who's not Brussels based. But here in Luxembourg, they have an interesting approach. First of all, in terms of languages. So everything that the health ministry communicates, it communicates in 5 languages. Well, that's a good starting point already to reach a vulnerable group, that you're reaching out in different languages and making the information available, particularly as regards preventative measures, how to wear your mask, how to maintain a social distance, what to do in case you have symptoms and so on. So they've really made an effort to communicate with vulnerable groups. And secondly, they've mobilized the NGO community who work with vulnerable groups, for example, the homeless, and they actually have set up mobile clinics so that the homeless, even in the time of lockdown, the homeless have access full-time to 24 hours a day to a medical clinic which they can walk into and also get advice on protecting themselves. Because of course, if you have somebody who is homeless, who's not, perhaps has substance abuse issues, has other issues with their health, you can imagine that that's quite a dangerous situation if they're walking around the streets among the rest of the population. So I think from a purely public health point of view, it's quite justified that we really make an effort to reach out to those parts of the community, as we do for people who are living in retirement homes, as we do for prisoners, for other populations who are in a special situation.
Thank you very much, John. Maybe on a personal note, to end with one more question that's intriguing for me, and I hear a lot about this from people here in Ireland. All of us, being curtailed in our freedom of movement, both at home here in Ireland as well as being able to travel to other member states internationally. From your public health point of view, are we going to have a summer?
I hope we have a summer. I'm not sure if the summer will involve traveling to the beaches in Greece or the Torremolinos or going to the Turkish resorts. I'm not sure how quickly we can actually re-establish free circulation from the point of view of leisure travel. What we're trying to do at the moment is to agree together on the importance of keeping essential travel open. And we've seen in the last few days, one of our biggest member states closing selectively certain frontiers. We do not think on the Commission side that closing of frontiers is a solution. It's a solution if you've no cases in your own country, but closing borders is not really the best. Borders are not the best place to carry out public health measures. If you think about it, it requires a lot of investment in resources and in screening and in controlling travelers, which would be much better employed elsewhere in the health system. So from our point of view, we think that the actual solution is not closing borders and not controlling the borders to the extent that's going on at the moment. We understand that there's a reluctance to see free travel continuing when countries are in lockdown, and that's a psychological problem rather than public health problem. But for us, we hope to get back to normal as quickly as possible. We're working on all sides in the European Union with the member states to try and make this return to normal as quick and as safe as possible. And of course, the summer holidays will be one of the aspects that will be involved there, because the tourism industry is indeed extremely important. And we will be publishing a plan on tourism and on tourism in the post-COVID period in the coming weeks. So we are looking at this as a priority, I would say.
Thank you very much, John. John Ryan, my sincere thanks for spending so much time with us today, giving a presentation about the EU vaccination strategy, but also being available to take so many questions we've had from the general public and from the press. Also, my thanks to our friends at the European Movement Ireland for making this event possible and assisting us to create this platform. Ladies and gentlemen, I understand that the slides that John has used for his presentation will be available to those of you that have registered to attend this event today. Thank you all very much for spending your time with us. And I hope, like for me, that you've been receiving a lot of clarification and understanding of what is going on with the EU's vaccination strategy, thanks to John Ryan. Thank you very much.
Thank you.